Hello friends, welcome back again to the Cortex YouTube channel. In this video, I'll be continuing on the treatment aspect of the beta blocker toxicity. So there is no one particular treatment for the beta blocker toxicity. So you have to tailor the treatment according to the patient, keeping the targets in mind. So what are these targets? So targets, the therapeutic endpoints or targets include heart rate more than 50 beats per minute, then blood pressure, that is systolic blood pressure more than 90 millimeter of mercury, and what else, your QRS duration less than 120 milliseconds, and your ejection fraction, LV ejection fraction more than or equal to 50%, and urine output 1 to 2 ml per kg per hour, and improved mentation. So these are the therapeutic goals that you have to maintain in a case of beta blocker toxicity. So let me revise again: heart rate more than 50 beats per minute, BP systolic BP more than 90 millimeter of mercury, QRS less than 120 milliseconds, LV ejection fraction more than 50%, urine output 1 to 2 ml per kg per hour, and improved mentation. So with these targets, let's proceed to the treatment aspects. First thing that we have to do is DI decontamination. GI decontamination. So early decontamination, okay, should be considered. So early means how much? Less than 1 hour. So you have to give activated charcoal. Okay, activated charcoal, it best when it's given within 1 hour of ingestion. So you can have an extended period of window in what is the in uh, extended release formulations. Okay, extended release formulations, you can have the extended window of giving activated charcoal. So okay, and what are the pharmacological methods of uh, treatment? Okay, so you can give fluid resuscitation, you can give glucagon, you can give what is known as adrenergic agents, you can give high dose insulin therapy, and you can give calcium. Okay, you can give phosphodiesterase inhibitors. So let's discuss one by one. Let's start with glucagon, because it is the line first line agent in the management of beta blockers. So what is the mechanism of action? How does glucagon acts? I already told in my first video of beta blocker toxicity, glucagon has independent stimulation or activation of adenylate cyclase enzyme. So it stimulates adenylate cyclase, which in turn causes a conversion of ATP into cyclic AMP, which in turn activates protein kinase A, which phosphorylates your calcium channels, and thereby increasing the influx of calcium, and the cascade further. So this is a mechanism action of glucagon. So here, if you talk about the pharmacokinetics, its onset of action is within 1 to 2 minutes of IV bolus injection. Then its peak action is seen within 5 to 7 minutes of injection, and duration of action is only 10 to 15 minutes. That is short lived. Okay, so you have to give continuous infusion to have that therapeutic effect. Okay, so what is the initial dose? Dose is anywhere between 3 to 10 mg 3 to 10 mg IV bolus you have to give. Okay, 3 to 10 mg IV bolus you give. After 15 minutes you check. After 15 minutes, if no response, no response, you can repeat IV bolus one more dose. Okay, same dose, you can repeat the IV bolus. If response is seen, you can give the infusion 1 to 5 mg per hour infusion. Okay, 1 to 5 mg per hour. So how I remember is you give 5 mg bolus and 5 mg per hour infusion. Titrate according to the hemodynamic goals. So titrate according to goals. Goals I have already discussed. Okay, so titrate according to the goals. So this uh, okay, this is about glucagon. I would stress on the mechanism of action by going back to that diagram where I have explained the beta receptors activity. So this is that diagram. See, this is your adenylate cyclase. This enzyme is independently activated by the glucagon. See, this is your glucagon. This stimulates this enzyme and thereby causing conversion of ATP into cyclic AMP. Once cyclic AMP is increased in the intracytoplasmic, cyclic AMP is increased, it will cause phosphorylation of calcium channels and thereby increasing the intracytoplasmic calcium. Okay, thereby bringing the action that we need. That is myocardial contraction, heart rate increase, and BP increases. Okay, and this stimulation of adrenal cyclase doesn't depend on the beta agonist. Okay, when we give glucagon, that is one thing. Okay, next, so what are the possible side effects of giving glucagon? Glucagon has this common side effect, that is nausea and vomiting. That is because of relaxation of LES, esophageal sphincter. Okay, relaxation of esophageal sphincter. So when this relaxation of esophageal sphincter is there, that means it is a risk factor for aspiration. So if the patient is already comatose because of beta blocker overdose, that means first you have to intubate and then you give glucagon. So first intubation and then glucagon, because glucagon carries risk of aspiration in comatose patients because of sphincter relaxation. So how to manage this nausea vomiting? You can give antiemetics. Hope you remember what I told in the previous video, because antiemetics, what commonly used antiemetic is and ondansetron. Ondansetron will it will cause QT prolongation. Okay, QT prolongation by itself, and glucagon also causes QT. Sorry, already patient is having beta blocker. Okay, so that also causes especially those beta blockers which have sodium channel blockade property, that will also cause QT prolongation. So in them you have to be careful. So you have to do ECG and measure QT before giving ondansetron. Okay, that is one point that I want to stress. Okay, so I think I made that point clear. Next, so that's about glucagon. Dose is 5 mg IV bolus followed after 15 minutes by 5 mg per hour infusion if response is there. Otherwise you give one more bolus and then start infusion. So what is the next step of management? That is your adrenergic agonist. If glucagon is not enough and you are not able to achieve the hemodynamic goals, then you can use what is known as adrenergic agonists, like your norepinephrine is the most effective, epinephrine, okay, dobutamine. So these are the drugs which increases the heart rate, and dobutamine decreases the systemic vascular resistance. while epinephrine and norepinephrine increases the systemic vascular resistance. All will increase heart rate. Okay. So next line of management, typically it started with 2 to 4 micro norepinephrine. Typically it starts with 2 to 4 microgram per minute. Okay. Next line of treatment is high dose insulin. High dose insulin is what? High dose insulin means in diabetic ketoacidosis you have used 0.1 units per kg. Okay, but here we are using 1 unit per kg. That means 10 times more than the that we use in DKA management. So it's also known as hyperinsulinemia, euglycemia therapy. We are maintaining the euglycemic state and providing more insulin and causes used in beta blocker toxicity. So how does insulin act? Why are we giving insulin here? Where is the picture of insulin in the management of beta blocker toxicity? Why we are giving? Why? See, one basic thing I want you to remember is when in rest condition, during rest, or in at restful condition, or in a normal physiological condition, heart uses free fatty acid for its activity. So heart uses free fatty acids in resting condition. So in stressful condition, what happens? Same heart switches its metabolism and uses glucose directly because it needs energy faster. So glucose is used in stressful condition by the heart. So if you give insulin acts as a positive inotropic agent by increasing the glucose utility by the heart. Okay, so that is the mechanism of action why we are giving insulin. So once you are giving insulin, and especially you are giving high dose insulin, so there is bound to this hypoglycemia bound to happen. Okay, so you have to give dextrose glucose correction also. You have to give dextrose simultaneously also. So insulin target is to maintain hemodynamic stability, and we have to, since we are giving insulin, we have to provide glucose, and you also know insulin causes hypokalemia, so you have to always also correct potassium. So before giving insulin, high dose insulin, you check glucose, serum glucose. Okay, serum glucose you check. If it is less than 200 mg per deciliter, you give 50 ml of 50% dextrose. Okay, IV 50% of 50 ml dextrose IV. This is first point. Second point, give regular insulin. I already told you the dose, that is 1 unit per kg. 1 unit per kg IV bolus you give. And then third one is you start the infusion of regular insulin, same dose infusion per hour, like 1 unit per kg per hour infusion. Okay, since you are giving infusion which causes hypoglycemia and hypokalemia, we have to always give glucose correction, that is using 10% dextrose at 200 ml per hour. So 200 ml per hour you start dextrose and titrate the insulin rate. See, what is my goal? My goal is to achieve hemodynamic stability, that is heart rate more than 50, blood pressure more than 90. So I want to maintain that. So till I maintain that, I increase the dose of insulin. I titrate the dose of insulin. Up to what level I can increase is up to 10 units per kg per hour. Up to this level I can increase the insulin rate if I don't meet any hemodynamic criteria. Okay, then fifth one is, see, if you go on increasing insulin, there will be hypoglycemic episodes. So you have to monitor glucose. You have to monitor blood glucose every how many minutes? Every 15 to 20 minutes. Yes, This is every 15 to 20 minutes, because you are using high dose insulin. You have to measure very quickly. Okay, then you have to titrate the dextrose. Titrate the dextrose according to titrate the dextrose to maintain glucose level in between 100 to 200 mg per deciliter. So insulin target is to maintain hemodynamic stability, but dextrose infusion target is to maintain glucose in between 100 to 200 mg per deciliter. So once seventh point is, once glucose, that is 10% dextrose rate is stable for 60 minutes, dextrose infusion rate is stable for 60 minutes, then you can monitor glucose. You can monitor glucose every 1 hourly. So till then you have to maintain, you have to measure, you have to monitor every 15 to 20 minutes. So you have to, along with that, I already told insulin also causes hypokalemia, so you have to monitor potassium also. So how to you check potassium. If it is less than 2.8 milliequivalents per liter, you give in potassium correction. That okay, you start the potassium infusion. So target potassium range is to maintain 2.8 to 3.2 milliequivalents per liter. So this is the target of potassium. Target of glucose is 100 to 200 milligram per deciliter, while potassium is 2.8 to 3.2 milliequivalents per liter. So whenever it goes below 2.8, you have to start the potassium correction also. So as you all know, side effect of insulin is hypoglycemia and hypokalemia. Okay. So what happens once you achieve the target, set the point of target is achieved, that is hemodynamic stability, heart rate more than 50, blood pressure more than 90, improved mentation, LV ejection fraction is more than 50% and all. That time you can stop the insulin infusion. Once you stop the insulin infusion, you need not immediately stop the dextrose infusion, because dextrose infusion has to be stopped after many hours of infusion, or insulin infusion is stopped. So because insulin infused will have action for so many hours, and if you don't supply dextrose, it will cause hypoglycemia and patient may die. So high dose infusion is continued until the resolution of toxicity and the hemodynamic goals are met. So till then you continue the infusion of the insulin as well as dextrose. Once all the criteria are met, hemodynamic stability is met and toxicity is reduced, that time you can stop the insulin therapy, but continue dextrose infusion for several hours after infusion stoppage, and then you can stop for dextrose infusion. So this is about high dose insulin infusion therapy. Next that you can consider is IV lipid emulsion therapy. It is simply called as ILE. Okay, IV emulsion therapy. So what is this lipid infusion? What is the pharmacological importance of this? So lipid emulsion, as you know, some of the beta blockers are highly lipid soluble, as I said, like PTB, that is your propranolol, pindolol, penbitalol, timolol and bisoprolol. So all these drugs, betaxolol, not bisoprolol, betaxolol, all these drugs are highly lipid soluble, and when you use lipid emulsion, they will be drawn to that lipid emulsion, and that lipid emulsion acts as a sink. So it's called as lipid sink model, or it acts as a pharmacological sink for these drugs. So it's mostly effective in lipophilic beta blockers. I already told the examples. Okay, so what is the dose? One word I want you to remember is it acts as a lipid sink, okay, model, or pharmacologic sink. Okay, next. So what is the dose? Dose is you have to use 20% of lipid emulsion. 20% of lipid emulsion. You have to start with 1.5 ml per kg IV bolus for 1 minute. Then you have to give infusion 0.25 ml per kg per minute. Till how long you have to give is not mentioned, but since we also use this lipid emulsion in local anesthetic toxicity, there we use for 30 minutes. So here also you can use for 30 minutes. If the toxicity is not reduced within 30 minutes, you can repeat the bolus once again. So what are the adverse reactions that are associated with lipid emulsion? So you are giving providing lipid, so your lipid will increase hypertriglyceridemia. So hypertriglyceridemia, hyper, oh sorry, so it will cause hypertriglyceridemia. So hypertriglyceridemia, you know, hypertriglyceridemia is a risk factor for pancreatitis, so it will cause pancreatitis also. And you also know some patients may get allergic reactions to lipid emulsion, and it's also know it will increase the viscosity, so it may cause venous thromboembolism, acute renal failure, acute lung injury, and fat embolism. Okay, so these are all the possible adverse drug reactions, adverse drug events following lipid emulsion infusion. So you can ask, sir, there is bradycardia, can we use atropine? Atropine is not effective, and simultaneously it is not harmful also in case of beta blocker toxicity. So you can ask, sir, there is effectively there is influx of calcium is not happening, so can we give calcium for these beta blocker patients? So yes, we can use calcium, but only indication is in refractory cases. So what I mean by refractory cases is when you use both the above mentioned therapy, glucagon and high dose insulin therapy, along with the glucose correction, dextrose infusion, if they are not effective, so then it can be termed as a refractory shock or refractory hypotension and bradycardia. In that condition, you can use calcium. So calcium, there are two forms of calcium, two formulations that are your chloride and gluconate. What we use commonly is gluconate, but what is the difference between both of them? So calcium chloride has more calcium content. So let's suppose if we take 10 ml of 10% of calcium chloride and calcium gluconate, calcium chloride has more calcium, that is 3 times more calcium than the gluconate. So if you want me exact figures, 13.6 milliequivalents. Okay, while this has some 4 milliequivalents. Okay, so this is the calcium concentration, 4.5 exactly, 4.5. Okay, so 1 gram of calcium chloride has 13.6 milliequivalents of calcium, while 1 gram of gluconate has 4.5 milliequivalents of calcium. Okay, and calcium chloride has to be given in central line. Why? Because if extravasated, inadvertent extravasation of calcium chloride causes tissue necrosis, and which you don't want, and risk of tissue necrosis or extravasation is more common when given IV peripherally. So that's why you choose central line, while the gluconate can be given peripherally. Easy to administer, but you have to use 3 times more ml. Let's suppose if you are using 10% of 10 ml calcium chloride, to get the same calcium you have to use 30 ml of 10% of calcium gluconate. Are you understanding it? So what are the side effects of giving calcium? So you are infusing or injecting the calcium, so you will bound to have hypercalcemia. So one logical side effect is hypercalcemia. So hypercalcemia can cause conduction block, okay, and worsening bradycardia. When there is conduction block, bradycardia can be worsened. So this is more common when you use chloride while compared to gluconate, because of obvious reason that it has more calcium. So what is the dose? So here I will tell the dose of calcium gluconate. So obviously here you are using 10% of 10 ml at the rate of 0.6 ml per kg IV over 5 to 10 minutes. Okay, followed by 0.6 ml per kg per hour infusion. So 0.6 ml per kg IV bolus followed by the same dose per hour infusion. Okay, then you are giving calcium, means you have to measure calcium because there is a risk of hypercalcemia. So ionized calcium level should be monitored how long? Every 30 minutes. So initially, thereafter you can use, later you can use every 2 hourly or 1 hourly. Okay, so what is the target calcium level? Calcium can be maintained up to 2 times the upper limit of normal range. So these are the this is the calcium protocol that is used in cases of refractory, underline the word refractory beta blocker toxicity. Okay, I will explain this with the help of this sorry, oh, where is that? Oh, that is there in the next page. Okay, yeah, this diagram. So what happens when beta blocker is given? This doesn't happen, phosphorylation of calcium channel doesn't happen, so calcium influx will be reduced. So when we increase the calcium from outside, exogenous calcium increases the extracellular calcium levels there, whereby entering of the calcium according to gradient. Okay, concentration gradient. So yeah, cytoplasmic calcium will be increased. Next, can we give phosphodiesterase inhibitor? Because your cyclic AMP, which is a very active compound, is degraded into 5-AMP, 5-AMP by using your PDE, phosphodiesterase. So if you block this enzyme, that means cyclic AMP action will be more, levels will be more, action will be more, so calcium will be more and contraction will be more. So but theoretically they are wonderful drugs, but there is no advantage over glucagon. No advantage over glucagon. It can be used as an alternative to glucagon when glucagon is not available. So what is the dose? What is the dose? It is easy, 50 microgram per kg IV bolus followed by 0.375 microgram per kg per minute. So what is the target? To achieve the hemodynamic stability. Okay, so it is not usually recommended, usually recommended or routinely recommended. So when you don't get glucagon, see, it is mentioned in Tintinella that the glucagon dose, your hospital may exhaust the glucagon dose that is needed. So your stores will be exhausted when you use glucagon in glucagon beta blocker toxicity. You won't have sufficient glucagon stores to manage beta blockers. Sometimes very oftenly you have to borrow from other stores. Okay, or you can use this phosphodiesterase inhibitors. Next, what is the role of sodium bicarbonate in this case? Okay, what is the role of sodium bicarbonate? Sodium bicarbonate can be used in severe acidosis. Okay, and when you get wide QRS interval on ECG. Why I am saying this? Because sodium bicarbonate has bicarbonate which will take care of the acidosis. It also has sodium. When you give this beta blocker, when patient is ingested beta blockers plus sodium channel blocking beta blockers like your propranolol, okay, carvedilol, acebutolol. So all these drugs additionally block sodium channels. In that condition, you can give sodium bicarbonate. Okay, there it will act as like it won't prolong the QRS duration. Okay, so its indication is one is severe acidosis and one is QRS more than 120 milliseconds. So what is the dose? 2 to 3 milliequivalents per kg over 2 minutes. 2 milliequivalents per kg over 2 minutes. bolus can be repeated, okay, or you can start the infusion. Bolus can be repeated after 2 minutes, or you can use the infusion. Okay, so this is the use of sodium bicarbonate. Or else, if if all the therapeutic options are not working, that time what you have to do, you can go for cardiac pacing, okay, or extracorporeal removal of the toxins like hemodialysis. So hemodialysis, extracorporeal removal, that is hemodialysis. Here, the pharmacokinetics or pharmacological properties of beta blockers plays an important role. That drug which is highly lipid soluble, highly bound to protein, or has a large volume of distribution cannot be amenable to your hemodialysis, because it will be distributed throughout the body. Okay, in hemodialysis we are only filtering the blood, so that drug which is less lipid soluble and has low volume of distribution can be removed by your hemodialysis. And sotalol is one example where you can use this hemodialysis. So okay, so this is about beta blocker toxicity. Once again, I will repeat: those who are having altered mental status and bradycardia and conduction delays has to be admitted to ICU for better care. And overdose of immediate release. So when to dispose the patient or discharge the patient. So overdose of immediate release. Whenever you get immediate release, whenever a patient consumes immediate release beta blockers tablets and who remain asymptomatic like after 6 hours of ingestion also, that means they are unlikely to get toxic symptoms further. So you can discharge them or you can send them for psychiatric evaluation. So overdose of immediate release tablets of beta blockers consumed, okay, and patient is asymptomatic for 6 hours even after consumption of tablets, that time you can send them or you can ask them to get one psychiatric consultation done. So these are the management of beta blocker toxicity. Hope you find this video useful and informative. If so, please like, share and subscribe and share among your friends, especially emergency medicine PGs and general medicine PGs. Okay, thank you.